others may join as they finish clinic, etc. But let's get started. So my great pleasure to welcome Dr. Gupta back to Queen's. He can tell you a little bit more about what that means, but it's actually a return for him. And I'll start by saying, I think we originally planned this visit for May 2020, and I've been looking forward to welcoming you. I had the pleasure of meeting for the first time in November 2019. Wanted to get you here, so I'm glad I'm glad we waited till we could get you here in person, because even though we're not being able to do rounds in person, I had a great time meeting with you today, and I know you've had a chance to meet our pediatric oncology team, and we'll be meeting more members of our global oncology team. So thanks for coming, and it's really nice to welcome you to Kingston when the weather is nice, and also that you can have a bit of a homecoming here. So I'd just like to introduce Dr. Gupta. He's a staff oncologist and clinician investigator at Hospital for Sick Children in Toronto. He's an associate professor, faculty for health policy, management and evaluation at the University of Toronto, adjunct scientist with the cancer research program at the Institute for Clinical Evaluative Sciences. He completed a PhD in clinical epidemiology from the University of Toronto, supported by a CHR Fellowship Award. He's one of the assistant chairs of the Lancet Oncology Commission on Sustainable Pediatric Cancer Care in low middle income countries. Sumit has worked extensively with pediatric oncologists and policymakers throughout Latin America, the Caribbean, and India. He currently holds grant funding from the Guerin Family Cancer Center, CHR, and the Terry Fox Research Institute. And really looking forward to your talk, Sumit. Again, thanks for coming. And looking forward to both this talk and your grand rounds tomorrow. And I'll hand over to you.
Thanks so much, Scott, for that super kind introduction. So yeah, thank you very much for this opportunity to be here. It is a little bit of a homecoming for me. I'm wanted actually to start by just making sure everyone knew I'm giving this talk from Chris Booth's daughter's room. So in case anyone sees the rabbit pillow behind me, that is not mine. Just to make clear, I'm grateful to Chris for the opportunity and the site as well.
And Sumit, I have to turn my camera off to make sure the bandwidth in the Booth family farm.
I appreciate that.
The kids are cheering you on. The kids are cheering you on.
So I actually did my undergrad at Queen's and lived in Waldron Tower for the first year of residence. So it is a bit of a nostalgic homecoming for me. And at dinner, I can give more details, but volunteering at the KGH Pediatric Oncology Clinic, which I did as an undergrad, is actually what got me started thinking about medical school. So KGH in that clinic in a large part is responsible for my career path and trajectory so far. So it's very nice to be back. I will share my screen and we can get started. So my general preference, especially in smaller groups like this, is to keep this pretty informal. So I am more than happy for people we can certainly do questions and discussion at the end, and there'll be time for that, hopefully. But I'm more than happy to be interrupted during as well. So if people have comments or questions or additions to make, we can certainly do that. So feel free to either throw something in the chat, which I and hopefully Laura as well will keep an eye on, or just to interject. I'm perfectly happy with that. So going to talk today about, in general, how can we improve childhood cancer outcomes in low middle income countries through advocacy, policy, and research, something near and dear to my heart, and in the general global oncology sphere, obviously it's near and dear to the heart of everyone here today. So when I was trying to think about how to put this together and think of sort of an organizing framework for this, what my mind kept going back to was a conversation I had probably 15 years ago, or maybe somewhere around there, when I was visiting my parents in Winnipeg, when I first had developed an interest in global childhood oncology and was expressing this to my parents, who were very lovely and supportive, but somewhat puzzled and had a couple of questions that they asked, which is, when it came down to it, was really, aren't there bigger problems to solve in those countries? Isn't it too expensive for those countries? And how do you then actually go about improving outcomes there? Which I think is the reaction for a lot of people when we talk about oncology in general, and especially when we talk about childhood oncology in low middle income countries. So those are the questions I'm going to try to answer to some extent today. And by doing so, I'm going to go through some of the work that we and others have done in the now a couple of years old Lancet Oncology Commission on Childhood Cancer. We'll also talk about first talk about childhood cancer in high-income countries, just to set the stage for this audience. And then afterwards, we'll end by talking about the Global Initiative in Childhood Cancer launched by the WHO a couple of years ago, and some ongoing work that we're doing at Sick Kids as well. So let's start in setting the stage, just to give a quick intro to childhood cancer in high-income countries. So this is the classic figure that any pediatric oncologist uses whenever giving a general talk about pediatric oncology, because it's the one we're most proud of. These are the Kaplan-Meier curves for children with ALL by period of time. And you can see that it really is one of the miracles of modern medicine, going from nearly incurable disease to, in the space of only a couple of decades, one in which the vast majority of children are cured. And if you think about childhood cancer in general, you can see that in high-income countries, we generally have around an 80 to 82% event-free, overall survival when you take all comers. And in Ontario, this is work that the Pediatric Oncology Group of Ontario does, and you can go on their website and look at pretty up-to-date data for Ontario children with cancer. You can see here that we're no different and maybe a little bit better than a lot of other high-income country jurisdictions, that in the most recent time periods for which data is available, Ontario children with cancer also hit about an 82, 83% 5-year overall survival rate, which is pretty incredible. Still work to be done, obviously, but pretty incredible overall. What's always more fascinating to me, though, and I think is a surprise to most people, is that very little of that increase in survival was responsible because of new drugs. So these are the drugs that we predominantly use to treat acute lymphoblastic leukemia, the most cancer, and the years that they were approved. And you can see that this is not rocket science, right? Like these drugs have been around for decades and are going to be familiar to basically everyone in the audience today as well. And so the vast majority of that increase in event-free survival that I showed you in that first curve of ALL did not come from new drugs, but simply learning how to use old drugs better. That's changed a little bit in the last little while with the advent of immunotherapy and such, but again, the increase from nearly incurable to, say, 80, 85% was due to these drugs, old generic ones. So let's start with the first question that my parents sort of asked me when I talked about being interested in global pediatric oncology, which is, frankly, aren't there bigger problems to solve in these countries? So as a reminder, the Millennium Development Goal number 4 was to, and is, to reduce under 5 mortality rates by 2/3, by 2015. And that entailed, at the time, a focus almost exclusively upon infectious causes of childhood mortality, which makes sense, of course. One of the great successes of global health in general has been the tremendous progress against childhood mortality that has been achieved over the last several years. So between 1990 and 2011, 106 different countries witnessed what were defined as accelerated declines in childhood mortality. And just as one example, if you look at the under 5 mortality rates in Brazil, you can see that over the space of 20 years, that those mortality rates decreased spectacularly from 129 to 59 per 1,000 live births. And then over the next 25 years, an almost equally spectacular decrease down to 19 per 1,000. And that can be mirrored in lots and lots of different countries over those same time periods. Similarly, there were 2 million fewer childhood deaths in 2010 as compared to 2000. This was another modeling and data exercise. And the vast majority of this progress was due to decreases in infectious mortality. So 80% was because of averting these common childhood infections and their devastating results. So that's one part of the equation. And then recall that in high-income countries like ours, cancer is the leading cause of disease-related mortality among children. And so therefore, when you put these two things together, by definition, cancer therefore accounts for a greater and greater proportion of childhood mortalities in dozens and dozens and dozens of these countries as progress against infectious mortality is made. So, we talk about the epidemiologic transition in adult NCDs, and certainly the same thing, although it's not really thought of in childhood, is applicable to childhood as well. So here we have data published in the Lancet Oncology a little while ago about the percentage of childhood deaths aged 15 to 14 due to cancer. And you can see that in high-income countries, it's 30% plus. In low-income countries, it's a much smaller amount. But again, as countries progress through that epidemiologic transition and infectious mortality decreases further, they kind of progress through this progression as well. So, for example, cancer is already the leading cause of disease-related death in this age group in multiple low middle-income countries, including Brazil, Mexico, and China. And when you think of those populations, you're accounting for a huge chunk of the world's population and the world's pediatric population. So I don't have to tell this group, you're more familiar than I am, about the increased focus on non-communicable diseases in adults predominantly, as you can see in World Health Assembly resolutions and the United Nations Sustainable Goals. And then in May 2017, the World Health Assembly, again, as I'm sure everyone here is familiar with, passed the cancer resolution as well. But that's really been an adult thing. So, then the question becomes, what has kept children out of the NCD spotlight? Because frankly, whenever children are mentioned in the context of non-communicable diseases, it's almost exclusively in the context of childhood lifestyle risk factors that translate into adult lifestyle risk factors that then translate into adult non-communicable diseases. It's almost never the presence and the burden of non-communicable diseases that actually happen in childhood. And so that with that, we'll transition now to talking a little bit about the hidden burden of LMIC childhood cancer. So again, this will be familiar. I know there's cancer registry work that the group here at Queen's is involved with as well. But really, if you think about all the steps that have to happen in order for a childhood cancer case to actually translate into registry into a database. So someone's actually got to recognize that a kid might have cancer. And then that kid has to arrive to some type of primary care and get diagnosed either by that primary care or appropriately referred to a secondary or tertiary level of care that can make the clinical and then pathologic diagnosis of cancer. Then that has to then be registered within a database, which may or may not exist, and only then does it become part of the unhidden burden of that is observable by policymakers and politicians and clinicians. And so obviously for the vast majority of the world, there are breaks in this links of chains running in, which result in a vast underestimate and therefore what we call the hidden burden of childhood cancer. So for example, this is work by colleagues at St. Jude's and other places looking at the extent to which children are covered by global childhood cancer registries. And you can see here that the vast majority of the world either has no cancer registry coverage of children or very limited subnational cancer registry coverage. And this figure doesn't even do justice to that, because you can see that, India and China, for example, are just classified as subnational cancer registry coverage. But really, when you look at the proportion or percentage of their respective populations that is covered by one of these subnationals, it's very, very, very small. So one of the questions that we asked in the Lancet Oncology Commission, which I'll turn to now, is can we more accurately estimate both the current and future burden of childhood cancer on a global scale? So here's where I want to start talking about the Lancet Oncology Commission, which I had the immense honor and pleasure of being one of the associate chairs. My colleagues, Reef Atatun, who's a health policy guy at very renowned, who many here will know, at Harvard, and Carlos Rodriguez Galindo, who's a pediatric oncologist and the head of global oncology at St. Jude's, were the co-chairs, and Lindsay Fraser, who's an amazing pediatric oncologist at Boston, was associate chair with me. But there were a multitude of working group leaders and commissioners on this that made this commission possible, which was launched about a year into pandemic. So I guess that would be about a year and a half ago now. So the basic structure of the Lancet Oncology Commission, you can see again the wide geographic representation of the commissioners and the different personnel that were involved with this, was divided into working groups, and you can see them here. One working group focused on trying to elucidate the burden of childhood cancer. That's another working group talked about gap analysis and looking at core packages of interventions. Another working group, one that I led, looked at cost and cost effectiveness. And then a final working group looked at how we brought this all to model and the effects of scale up. So this was really, although I didn't think of it this way at the time, was really an attempt to answer those same questions that my parents asked me at the dinner table all those years ago, and that many people ask. So we're first going to talk about our the first working group. What did we do to look at the burden of childhood cancer? And I'm not going to go into great technical detail, but basically led by colleagues at Harvard, built a model in an attempt to get past this roadblock of not having cancer registry. So could we use country demographics and information about population genetics to model the number of incident cases of childhood cancer in countries that did not have childhood cancer registries? And then using variables by which we could model how much access to primary care a country had and whether there were appropriate referral pathways for tertiary care. Could we model both incidence and survival? And again, I won't go into a lot of technical detail, though I'm happy to answer questions to the extent of my ability if people are interested. So what I really want to focus on, though, is the results. And so this was the first set of results that were released looking at the incidence. And a couple of things I want to bring to your attention here. First, previous estimates had been of about 175, 180,000 children diagnosed annually on a global scale. And what the model, by contrast, showed was that when you took into account underdiagnosis and such, that even if you just talked about diagnosed cases, you were talking about more than 200,000 children per year. And when you took into account the estimated proportion of undiagnosed cases around the world, you're actually talking more than 400,000 patients, childhood patients a year who develop cancer on an annual basis. And so on the left here, you can see both the annual projected and the cumulative projected burden of childhood cancer globally going forward. This is a breakdown of those projections going forward by geographic region. And so the other thing that I want to pull your attention to here is that by 2030, the African continent is anticipated to account for nearly half, or maybe even just over half, of the global childhood cancer burden. And that's a point that the Lancet Oncology Commission on Cancer in Africa, which was just released, made loud and clear, hopefully, as well. Oops. So this is just breaking the estimates down by both diagnosed and undiagnosed proportions and by geographic region as well. And so again, you can see that this is the current burden. So this isn't projecting forward, but you can see that again, even now, Africa accounts for a huge proportion of the global childhood burden, followed by South Central Asia. And then when we brought survival into it in a separate model and then combined the two, when you put it all together, the estimate was that between 2020 and 2050, there will be approximately 14 million new cases of childhood cancer worldwide. Of those, if the current situation remains the status quo over that time period, over 6 million will be undiagnosed. And without additional improvements in access to and quality of care, over 11 million of those kids will die, of which over 9 million, or 84%, will be kids who live in low middle income countries. So just showing that what we all suspected, the burden of childhood cancer is far greater and far vaster than what previous estimates that relied only on cancer registries would have shown or implied. So don't these countries have bigger problems? Yes, of course. There's lots of issues that need attention, both in low, middle income and high income countries. But to argue that childhood cancer is not a substantial cause of childhood mortality and poor child health on a global scale just simply isn't true. So the next question that my parents asked in that different conversation was, does it actually make sense to concentrate on those because of cost? Isn't it too expensive for these countries to be able to justify spending, precious resources on treating children with cancer? And so where I wanted to start this section, talking about this section, was about the Disease Control Priorities Project, which some people here will be, I think, very familiar with, but others maybe less so. So this is a collaboration, a longstanding collaboration between the NIH and the Fogarty Institute and the World Bank. And it's essentially an effort to identify the most cost-effective health interventions for policymakers in low middle income countries. And so there's been a couple of different editions. In the third edition, they decided to take what were previously chapters and explode them into volumes as well. And so there was a cancer volume instead of a cancer chapter. And I was privileged enough to be asked to lead the childhood cancer section of the cancer volume. And so I remember having a section leader meeting in Washington, D.C. And I was very, very junior at this stage, and getting up and making this passionate plea for why childhood cancer made sense to include in these package of priorities, making essentially the argument that I just made for you, right? Cheap generic drugs, these are kids and epidemiologic transition. And essentially everyone around the table, who I didn't really understand at the time, included a lot of health economists, turned and looked at me and said, okay, that's great. That makes a lot of sense. How much does it cost? Like, oh, I don't know that. I definitely don't know that. And I don't think we know that in general. Like, well, how much does it cost in high income countries? Like, I'm actually not sure that we know a lot about that either. And I remember someone making the point that you don't need to just convince the Minister of Health, you need to convince the Minister of Finance as well. And that really stuck with me. So, started to then make the argument that, like I said, cheap generic drugs, theoretically, there's lots of life years to save. And, for example, in Burkitt's lymphoma, a much less expensive regimen than what we would use here in high-income countries can still cure a substantial proportion of children. A few doses of cyclophosphamide can actually cure, and this has been well shown by our African colleagues, up to 50% of children with Burkitt's in the African context. So I basically made this theoretical argument that it should be cost effective. And thankfully, maybe because they felt sorry for me, that's a distinct possibility, treatment of selected childhood cancers was included in the package of recommendations that for cancer-related interventions for low middle income country health policymakers and government officials. But again, that was theoretical, and even though it was good theory, we didn't really have numbers to back that up. And so again, I realized that a major barrier to creating childhood cancer policies in a national context was the lack of data on cost and cost effectiveness of childhood cancer treatment. And there was this assumption, whether it was my parents or whether it was policymakers in ministries of health across the region, that childhood cancer treatment was too expensive for LMIC health systems. And together that led to a lack of priority afforded to development of childhood cancer treatment delivery systems. And so the question that I and others asked is, well, then can we determine the cost and cost effectiveness associated with delivering childhood cancer treatment in a diverse range of established treatment units in LMIC settings? And that was essentially the task that we set ourselves in working group 3 of the Lancet Oncology Commission, looking at cost and cost-effective analysis. So I had the pleasure of collaborating with some amazing people. We basically identified 3 pediatric oncology treatment units, and we wanted to be geographically separate and also be representative of different resource settings and different childhood cancer resource availability. And so we ended up going, mainly because of connections and pre-existing relationships that we had with some centers, with the childhood cancer treatment in San Salvador, in El Salvador, led by an amazing oncologist, Dr. Somath Fuentes-Alabay, the childhood cancer treatment in Accra at Corlibu, who I understand some people here have connections and collaborations with as well. The pediatric oncology unit there is led by the Force of Nature, Professor Lorna Renner, and then the center in Guadalajara, led by Dr. Zubieta, who's pictured there. And this work was also led by myself and health economist Sue Horton and my colleague Nicola Bacta at St. Jude's, whose pictures are there as well. And so this is a hard table to look at. Don't worry about the details, but essentially just to make the point that these three units did actually represent pretty different levels of childhood cancer service, right? So for example, in Guadalajara, there was bone marrow transplant. In Corlebu, there were certainly chemotherapy and surgery, but even radiation was relatively limited, right? And you can see that 5-year overall survival was estimated at 35% in Corlebu versus 50% in San Salvador versus 70% in Guadalajara, Mexico. So again, a different range of services and a different range of outcomes given those services. So the first thing we did is actually determine the annual cost of maintaining each treatment unit using a previously trialed costing tool. And this wasn't rocket science, right? This was actually pretty logical. So we simply just broke down what the cost would be into components. So personnel, medications, diagnostics, overhead, just everything you could think of. In each of these units, some data, but very little, was available retrospectively. And so most was actually collected prospectively over a 2 to 4 week period. So we'd have someone in the unit who basically recorded over a 4-week period how many CBCs were done, how many chest x-rays were done, how many pathologies, how many surgeries, how many inpatient days, et cetera, et cetera, et cetera. And then we were able to assign costs to each of those units, essentially. So again, cost effectiveness for those who haven't dabbled in this, and I put the caveat, I am not a health economist. I just have had the pleasure of working very closely with some for a while now, and so I've picked up some of this stuff. But cost effectiveness isn't rocket science as well, right? If you know for a particular childhood cancer unit, and this is now conceptualizing that unit as one single intervention, right? The intervention is the unit itself. But if you know for that unit how many number of new kids they diagnose annually, what 5-year survival those kids are able to accomplish, and what that country's life expectancy is, then you can actually pretty simply calculate the annual life years saved that you can attribute to that childhood cancer treatment unit. And then if you've determined, as I discussed on the previous slide, what the annual cost of maintaining that treatment center is, you can combine those two to get the cost per disability adjusted life years saved. And from there, if you know the gross national income per capita of that country, then you can compare those two. What's the cost per life year saved, to put it in a more understandable way, and compare it to the ratio of the gross national product or income per person. And that gives you a measure of cost effectiveness. And so there's debate about these thresholds, about what to consider cost effective and what not to. So take that under consideration, but a pretty well established one, and the one that the WHO choice methodology started off with using anyways, is that a ratio of cost per DALY or life years saved to GNI per capita under 3 is considered cost effective. And a ratio that's under 1 is considered very cost effective. And like I said, there is some debate about those thresholds, to be fair. So this was, again, work in the Lancet Oncology Commission, where we took all these 3 centers and then put them all together. And you can see here the straight out costs in Ghana, El Salvador, and Mexico per patient. And you can see that it was an outlay of about 10,000 US dollars at the time per patient in Ghana, around 28,000 in El Salvador, and around 50,000 in Mexico. Excuse me for 1 second. Excuse me. And one of the interesting things to me anyways was that the ratio of cost per new diagnosis to GDP was actually remarkably consistent across these across these 3 centers, ranging between 6 and 7, which was fascinating to me, actually. And you can see there just the cost per new diagnosis and the cost per life saved across these 3 centers. But then here's where the meat of it is. So what happens when we take that cost per DALY averted or life years saved, which is in the blue X's there, and compare it to the 1 times per capita GNP threshold or the 3 times. And you can see that in all of these cases, the cost per DALY averted associated with maintaining a childhood cancer treatment unit is below, and in some cases far below, even the very cost-effective threshold. 0.68, 0.41, and 0.31 respectively. So the key points of what we found as part of this Lancet Oncology working group was that across the range of settings represented by these three centers, treatment units for childhood cancer represented very cost-effective interventions, and that was despite major differences in both the services provided and the outcomes achieved. So since that time, a great fellow of ours, Alistair Fung, did a systematic review of cost and cost-effectiveness studies in childhood cancer treatment in LMICs, of which there are a few, but the few that have been there have found similar findings. And then what we did is actually take what we were finding in terms of cost effectiveness of childhood cancer and compared it to select interventions targeting, say, childhood infections or adult cancers. And what you can see here is that the cost per daily averted is not that far off, but that of what's associated with interventions like the rotavirus vaccine and newborn home visits. And you can see as well that they compare very similarly to different women's cancers interventions, like Ghanaian evidence for screening breast exams and treatment of breast cancer, or for cervical cancer, or mammography and breast cancer treatment in Mexico. So that, these figures are very, very comparable. So, it's hard to argue that, for example, breast cancer should be covered by a national health insurance scheme, but childhood cancer shouldn't. And in fact, I still say these work was all published, and the Ghana data was published a couple of years ago on its own. And I still think that, if it contributed to this announcement, which I'll talk about in a second, then that might be the most impactful study I've ever done and will ever do in my career potentially. So, in Ghana, the National Health Insurance did cover breast and cervical cancer. And so the childhood cancer advocacy community in Ghana was able to take these findings and sort of point out and use it to inform their advocacy that, wait a second, childhood cancer, which is a much smaller absolute outlay of funds compared to breast or cervical, is just as cost effective. And so certainly that wasn't the only thing that went into this success, but it was, I think, one of the things that led to this. Much more important, to be frank, was the amazing advocacy of lots of stakeholders on the ground. But just a few months ago, at the tail end of 2021, the Ghanaian Ministry of Health announced that that the childhood cancers, at least some to begin with, and some of the most common ones, would be included in the benefit package for their national health insurance scheme. So that was a massive, massive win. Okay, so remember, my parents' questions at that dinner table 15 years ago was, don't these countries have bigger problems? We've talked about addressing why that. No, this actually is a problem that we should prioritize. Isn't it too expensive? Well, actually, no. It is cost effective, and just as cost effective as the interventions that we currently do use. So then we turn to this last question of, well, then, okay, how do you actually go about improving outcomes? And so the dominant model for a couple of decades was what we call twinning in the pediatric oncology world. And that's how we try to improve childhood cancer outcomes in low middle income countries. And all that is, it's a sort of pediatric oncology specific term for what we all know, right? A partnership between one or more high income country and one or more low middle income country centers that involves ideally a bidirectional exchange of disease specific expertise with local knowledge and capabilities. And sometimes there's resource or funding that flows through these twinning relationships as well. And there are examples of spectacular successes in the pediatric oncology world through these twinning models. So for example, I mentioned this to one or two people today. There's an amazing group of oncologists in association that I had the privilege to work with, as did many others in Central America, and they've done amazing things in terms of improving their event-free survival rates there. Sick Kids has a now long-standing partnership with with 7 units in 6 different English-speaking countries in the Caribbean, and we can talk more about that at some point. But this is a graph that I put together, or a figure I put together a long time ago, actually for the first, that DCP volume that I mentioned, of just some very select, there are lots more than this, but some select twinning relationships. And, why I still use this figure is, you can see that line number 9, which represents a twinning relationship between a university and unit in the Netherlands with an amazing pediatric oncology center in Yogyakarta in Java, in Indonesia. And they've done amazing things, right? Like they've published a lot and shown how much impact that twinning relationship has had, which is amazing. But there are probably another 50 centers in Indonesia that could benefit from the same type of twinning. And that's just in Indonesia alone. And there just isn't the resource or willingness or number of centers to establish that kind of detailed, intensive twinning relationship across all of Indonesia, let alone the rest of the LMIC world. So really what we need instead are governments to create effective national childhood cancer programs. And I know this is, like duh for adult global oncology folks, because you guys have been banging the childhood cancer plan drum for a lot longer. But, because childhood cancer is relatively small and obviously rare compared to the adult burden, twinning was the accepted model for a long time, and there's still a huge place for that, but it, I think, took the pediatric oncology community a little bit longer to latch onto, oh, we're going to hit a ceiling unless we get governments and national plans involved as well. But then the question is, how do you do that? And so this is where Working Group 2 came in. And there were a couple of arms here. I'm actually not going to spend a ton of time on this because it's a pretty complicated methodology that others would be able to speak to with more detail than I am. But one of the arms, and this is my colleague Avi Denberg, who lots of you know very well, and hopefully you'll have to give a talk where at these rounds at some point in the future where he can talk more about the methodology. But one of the things that Avi did was do case studies of countries that had already made efforts towards creating systems of childhood cancer care, but of varying degrees of success. And so did in-depth qualitative case studies of 5 countries that met this sort of definition. And again, this last point is a very superficial and maybe unjustifiably superficial summary of what was a lot of work and a lot of really robust and rich data that came from these qualitative studies. But the key success factors were stakeholder cohesion, a well-resourced civil society organization or multiple organizations, and capitalizing on windows of opportunity, including in some cases NCD and UHC or universal healthcare efforts. There were other really important lines of work in this working group. So Drs. Catherine Lamb and Paolo Friedrich, 2 amazing pediatric oncologists at St. Jude's, put together a bunch of different packages in terms of steps to take to move from the lowest level of childhood cancer service delivery to the highest, and so that you could sort of figure out where you were as a jurisdiction or as a hospital even, and then see what was recommended to progress further. And that could be done both at a institutional level or at a jurisdiction level. And there were both tools to assess where you're at. And then, as I said, these packages to sort of try to move forward in that spectrum as well, recognizing that there was context-specific adaptation there as well. Again, I am embarrassed to have given that slim treatment to this was to the huge amount of work by tons and tons of people that this represents. But for those who are interested, we can talk more, or the Lancet Oncology Commission is freely available online as well and goes into much more detail about these packages and some of the methodology as well. So then the last part of the Lancet Oncology Commission was trying to bring all of this together and say, okay, so if we actually got our houses in order and actually improved the situation for children with cancer on a global scale, what would that actually buy us, right? What would the benefits be to actually addressing the childhood cancer global burden? And so this is where Working Group 4 came up, modeling and scale up. And so what we tried to do, using that model that projected the incidence and current on survival that we were on track to achieve all the way out to 2050, is look at what if we use different scale-ups of different interventions and what would the effect be on some of these anticipated deaths. And so, for example, we estimated through these modeling exercises that increased access to primary care and referral would avert sort of around 900 million of those anticipated deaths. If we had improved social support, which would then translate into a decrease in abandonment of therapy rates, that would save 250 million. If we expanded the treatment of the availability of treatment and improved the quality of that treatment and the care that was delivering that treatment, then we could avert 2 million deaths. And you can see that one of the things, and this isn't, this is intuitive as well, that only investing in one part of the cancer journey gave you impact, but gave you a blunted impact. Because of course, if there are roadblocks at each stage of the cancer journey, fixing or addressing one of those roadblocks just leads to another roadblock down the road. But if you did a comprehensive package of scale up of packages that addressed all of these three things, then you could theoretically save 6.2 million of the upcoming deaths, which accounts for over half of the total projected deaths that we think are going to happen between the 2020 to 2050 period. So if we then so that's what we want to aim for, this comprehensive scale up. And if we did that, the reduction in the number of childhood cancer deaths would be greatest in LMIC, lower middle income countries, followed then by low income countries. The greatest improvement in 5-year survival, however, would be in low income countries. And the total number of undiscounted, and we can go into what that means later if you want, life years gained was an estimated 318 million associated with this comprehensive scale up. Now, taking the cost figures that that we obtained from some of those cost and cost effectiveness analyses that I described before, we were then able to tell not only what that would cost, but given how many kids we would save, what would the economic benefit be from that as well? And so the projected cumulative treatment costs of the comprehensive scale that we were proposing amounted to about $17 billion in 2020, rising to $228 billion by 2030, rising to $590 billion by 2050. But the estimated global lifetime productivity gains for all the children you had saved, and this is where the pediatric part becomes an advantage, because you save a kid and you've got potentially 50, 60, 70 years of life ahead of them. A lot of those years are going to be productive years from an economic point of view. So the estimated global livelihood productivity gains would be over 2.5 trillion. And so the net benefit would be almost $2 trillion, which is actually a return then of over $3 for every dollar invested in scale up. So this is our pitch to the Minister of Health, Minister of Finance, as I alluded to before, right? It's the morally right thing to do. It addresses what is a significant problem in many of these countries, but it makes economic sense as well, because you are going to get a return and a positive return on every dollar that you invest in this, if it's in this comprehensive scale up. What if we can't fully scale up, but can achieve partial scale up? What if we vary our assumption of how productive survivors will be in their adult years? And essentially in any of these sensitivity analyses or any of these variants of assumptions, any degree of scaling up of health interventions for childhood cancer was projected to produce lifetime productivity gains that exceeded the costs of the scale up. So again, if you can't achieve the full package, you will still achieve a net economic benefit, even if you partially move up that capability ladder. This I'm going to skip because this just stratifies this by different income levels. So, I always joke that this infographic represents, like countless numbers of man hours and woman hours and effort and all that sort of stuff. But essentially, this was our sort of headline message then, right? We can prevent over 6 million deaths in children with cancer over the next 30 years. That's and the investment investment could therefore save more than half those number of deaths, and actually productivity gains will far exceed the treatment costs. Okay, so that was the Lancet Oncology Commission. It wasn't because of the commission, these things happened in parallel, but for those who aren't aware, in 2019, the WHO launched in partnership with St. Jude's and many other places and NGOs and stakeholders, the Global Initiative for Childhood Cancer, or GICC, and I was privileged enough to be a stakeholder that was invited to these launches and to contribute as well. So again, this is a collaboration with many, many different things with organizations, but our International Society of Pediatric Oncology and St. Jude Global are two of the key ones. And essentially what we're trying to do as part of the GICC is, having identified 6 major childhood cancers responsible for a large percentage of the overall childhood cancer burden worldwide, is to, by 2030, achieve at least a 60% survival rate for childhood cancer, or these childhood cancers globally, and to reduce suffering for all, giving not just a nod, but its due place to palliative care and preventing pain and suffering. And essentially, we'll be able to save 1 million additional lives if we do so. And so, this involves lots of different regional and global which I won't get into it in great detail. There's what we call the Cure-All package. These are a bunch of technical documents, a lot of which came from the Lancet Oncology Commission or were based on those, that government or jurisdictions can use to help identify where they are at the moment with the local capacity and how to move forward. There's a huge number of people involved that I won't go into individually. And the idea is, and this has happened over the last couple of years, to start off by identifying 5 or 6 different demonstration countries where ministries of health have been enthusiastic about embracing progress against childhood cancer. And these were some of the first countries that raised their hands as wanting to join. And since then, there's been actually many more. Just as a couple of things that we've been involved in the Caribbean, we were obviously a stakeholder given the Sick Kids Caribbean initiative. And so this picture was taken February 2020, so right before the world changed. But there have been initiatives that have continued in the Caribbean, including more cancer registries and some initiatives with drug access. In Peru, which is actually one of the most amazing demonstration countries that has done spectacular work even through pandemic, which I'm happy to talk about afterwards. But right before pandemic, we went down because they were very interested in the hub and spoke model that we have here in Ontario. We have 5 childhood cancer centers, but we have over 13 or 14, I think, satellite centers that provide adjunctive care as well in a very well organized, full healthcare system type of way. And Peru was looking to emulate that. So this is one of many meetings that I and one of my colleagues had down there with various ministries of health to help inform their satellite plan. I mentioned the Ghanaian childhood cancer effectiveness work that we did there. And in fact, we've since expanded that as well at our work in PERC, where we, based on feedback from other centers in sub-Saharan Africa, that said, actually, we'd love to know what our local numbers are as well. And so we actually extended the cost effectiveness work and repeated it in centers in Nigeria, Kenya, Tanzania, and Zimbabwe, and came up with lots of different numbers that they were able to then take to their ministries of health as well. And in fact, the Kenyan Ministry of Health is negotiating has agreed in principle to cover and to extend the coverage of childhood cancer treatment based on this work and other work, and the details are just being finalized now, but that is looking very promising in the next couple of months. And in fact, there's an ASCO session where one of the amazing Kenyan stakeholders and advocates is going to talk about that work. And then this is work that hopefully you'll have Avi Denberg to talk about at some point as well. This is another main focus of our group at PERC that Avi leads, who has a very strong interest in drug procurement and availability and sustainability of procurement. And so Avi leads a really amazing collaboration between basically all the childhood cancer treatment units in Kenya, Tanzania, Rwanda, Uganda, and some in Ethiopia as well, where they are prospectively tracking on a weekly basis stockouts of all the childhood cancer relevant anti-neoplastics and supportive care drugs, and also conducting qualitative interviews with stakeholders. And one of the best things about this initiative is that people from the ministries of health of various of these countries, as well as from the East African community and the World Bank, have been part of this from the beginning, as represented by the picture. So we're very hopeful that the results, which are just starting to come through, will really feed back into tangible and impactful policy change. And for those who are interested, Avi led, and I had the honor of participating in as well, a similar study in the English-speaking Caribbean, in Trinidad and Tobago, Barbados, Bahamas, and Jamaica. And that was published in Lancet Global Health there for people who are interested in the details of that methodology. And there's ongoing discussions with PAHO, the Pan American Health Organization, and some ministries of health there. Those have stalled during pandemic, but there's definitely appetite to keep it going as well. So we're hopeful that that will continue to progress as well. So that's a bit of a whirlwind tour, but just to, key messages. So I hope that I've convinced you that, improving childhood cancer outcomes in low middle income countries is justifiable, to say the least, to address a growing contributor to global childhood mortality, that doing so is both feasible and cost effective and will provide a significant return on investment in the future, that increasing availability of tools and resources to assist national governments in this challenge exist in the context of international initiatives like the WHO Global Initiative on Childhood Cancer, but that a huge and massive amount of work still needs to be done. And so there's every space and opportunity for as many people who want to contribute to this in any way as possible. There is a massive number of people whose efforts led to the work that I have highlighted, and some of this work is not mine, but these are just a few of them. As I say, in the bottom right corner, there are many, 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 many other people have contributed this as well. There's just no time or space to put everyone's names down. And so with that, I'd like to thank Scott and all of you for the opportunity to present this work, and I'm happy to take questions or to just listen to a discussion as well.
So thanks very much, Sumit. Amazing talk. I think we have to thank your parents for asking such probing questions that drove you to, first of all. But also,
my parents have always been a little bit doubtful of what I do, so this was one of many similar conversations over dinner I could tell you about.
I mean, I was thinking, Sumit, that I need to have a chat with your parents, because when my kids want to do things I don't think is a good idea, we have a family meeting, they make a decision chart, and I might read a chapter in a parenting book. And you went and you co-wrote a Lancet commission. So that's very impressive. Your parents did a good job, and they must be very proud.
But I think it's incredible how, this kind of, two-pronged approach, which is not only demonstrating this is the right thing to do, right, to improve equity and but the very important part of translating this into action, of making people realize it's also like the smart thing to do economically. So really incredible work, and thanks for sharing it. Maybe I'll open it up for questions for Sumit.
I think Nazik has her hand up. Nazik, do you want to go ahead?
Nazik, go ahead. I apologize.
Yeah. So amazing. I just don't know what to say, but it's great. And Chris and I had the chance to review this for the editorial commission. So that was great work. My question to you is, how like this kind of work, how can we leverage or encourage South-South collaboration in order to make it happen? And train people who can do it, make sure that they are talking to each other, because this is in Ghana, Kenya. How do you think we can make this kind of be, like, for example, through the IGAD, or take it to the level of the African Union? I think we need to go beyond and this is what's the discussion that's happening in our world now, is that we need to go beyond countries and take it into that level in order to decrease the disparities between countries. So, do you have any thoughts or suggestions for or for all other, or what you experience in that?
Yeah, so Nazik, I think that's an incredibly important comment and observation and question. I think, when putting this talk together, I was reflecting and obviously went back to the commission and reread parts of it just to refamiliarize myself. And I think what I'm most embarrassed about, although I don't know how we could have done it differently at the time with time constraints that we had, is that those first 6 authors, including myself, are all high income country based, right? And which feels now a little bit uncomfortable to be frank, right? So what we and at Sick Kids and what I've tried to do is just be very cognizant, both in some of these broader initiatives and in some of our local initiatives, about exactly what you said. So I'll give you 2 examples. One, in the GICC, it started with the 2 or 3 main people at the GICC who the WHO hired to do this being people from the US, right? That has changed. The 2 main people there are actually low middle income country based pediatric oncologists now. The PAHO group, that's a subset of the GICC, are 3 pediatric oncologists, actually 2 pediatric oncologists and 1 epidemiologist, who are from Peru, El Salvador, and Brazil, respectively. And they're responsible for doing and making the collaborations across that region, right? So I think, and even in the last 5 years, I think these organizations have moved closer to that goal. The other more local and personal example I'll give is the initiative the collaboration I had mentioned, where we extended on the invitation of some of these centers to redo our cost-effective analysis in the 4 centers in Nigeria, Kenya, Tanzania, and Zimbabwe. We very purposely built a core component of that collaboration was a series of lectures on how to do cost-effective analyses, and identified 2 or 3 people, or asked each center to identify 2 or 3 people who would attend those teaching sessions. So the idea was not just to conduct this collaborative cost-effective analysis across these 4 centers, but at the end of that collaboration, have people in each of those centers who had the skills to do further cost-effective analysis and could do it with each other, right? Because now those 4 groups kind of know each other, right? I'll be frank, that hasn't happened yet, but of course COVID, and there's lots of reasons for that, but that was certainly the intention. And so I think one of the main things is just being aware of it, right? But I think we try very much to not be, to any collaboration we have, to try to be the endpoint, to not just meet the goal, but have it so that our presence isn't necessarily required for the next step in that collaboration to happen.
Thanks, Naz. A great question. And I know South-South, promoting South-South collaborations is very important to you. So thanks for that. Chris, go ahead.
Scott, actually, Chris, before you say that, can I just say one thing?
Yeah.
Nazik, and maybe at dinner we can discuss this further, because I'd love your opinion on this. What I find difficult, though, is we were the ones that were able to access funding, right? And grant funding for that collaboration, right? So one of the reasons nothing has happened, one of the reasons that hasn't gone forward might simply be that if we're not bringing grant funding to the table, they might not have access to grant funding as well. And so maybe over dinner, I'd love to hear your thoughts on how that barrier can be overcome.
That's good. Yeah.
Thanks. Chris, go ahead.
Thanks, Scott. Sumit, that was just a great presentation, an amazing body of work from you and your colleagues. My question for you relates to the concept of value. And in some ways, your world's like the opposite from my world. You use drugs that are 50 years old and cost $5 and you cure a kid. But I'm wondering, as you're starting to mobilize resources and interest in expanding capacity for pediatric cancer care globally, are you guys worried or starting to see examples that emerging cancer systems are jumping at the new shiny tools in our toolbox rather than ensuring the fundamentals? It's a real problem in adult oncology. I was wondering how you guys deal with that in pediatrics.
So I think for the reason you mentioned, the appropriate and increasing emphasis on value in adult oncology, both in high-income countries and globally, hasn't jumped too much to the pediatric context yet, because exactly of what you said, right? If you can treat 50% of burkitt's with, a couple of dollars worth of a cyclophosphamide, it's hard not to argue that's value. What has happened in the past is, for example, the emphasis on building the shiny new bone marrow transplant unit in a center where your treatment-related mortality rate for regular old ALL therapy is 15%, right? Does that make sense from a value point of view, for example, or does the much less sexy training your nurses and good blood product availability and quickly being able to give antibiotics, is that where the value lies? I do think with the advent of immunotherapy for leukemia, with the advent of CAR T cells and these things, I think that's going to come much more into play than now, right? In the next 10, 20 years, because now for a long time, we didn't have the new shiny things in pediatric oncology. Now we do, right? And so how those are going to get incorporated, I have to say, I get lots of, one of my 3 sort of research hats is ALL. And so I do a lot of ALL clinical trials in North America. And so I get asked a lot by low middle income country centers to talk about immunotherapy and ALL and things like that, which I'm happy to do. But I do always wonder, okay, at the same time, if immunotherapy works for a lot of ALL, maybe it does have a role, right? And in a place where conventional chemotherapy is associated with a lot of toxicity, maybe there is a role for immunotherapy and sort of leapfrogging past some of that. But at the same time, or could it be danger to being the new shiny thing instead of the fundamental stuff that cures the vast majority of kids with, say, ALL? So I think hasn't crossed into pediatric oncology much, is starting to cross into pediatric oncology in high-income country centers, and I suspect will be increasingly relevant in low-middle-income country centers as well.
Thanks, Sumit. Thanks.
Thanks very much. And we've gone a little over time, but great discussion. Thanks again, Sumit. And enjoy your evening in Kingston. For those of you interested, Dr. Gupta is going to be presenting again tomorrow morning on adolescent young adult oncology, something I'm really interested in hearing about it as well. Thanks again, fascinating talk, inspiring work. Thank you for the work you do. And we'll see you again tomorrow morning. Have a great night.